I'm going to record this and then start sharing the screen. Okay, I'm just trying to admit some more people just as we're starting. Someone's written something in the chat. Good evening. Thank you.
Hello.
Hi there. Okay. So hopefully you've got this talk. Just click up there. There we go. Okay. Obviously, you all know me. I'm Dr. Alistair Sanderlands. So we're going to crack on with this ECG lesson 2 today. So the idea of this evening is to be able to be confident to identify when an ECG is a bradycardia. We need to think about knowing the causes of a bradycardia. We'll go through that. We need to progress to use correct interpretation with the algorithm that I've got within the slides. And we'll talk probably a little bit about the treatments. Okay, I'm very happy to have questions at any time. I don't always see the chat. If you try and, if you want to talk to me and ask a question, I'm very happy to answer. Okay. Okay, so we're going to start off with Kahoot this evening. I want to have a look at some concepts about bradycardias that we can try and test, and just introduce yourself to them, just trying to see what you know. We'll talk about the important signals for bradycardias, and again, probably recap a little bit of last week. Again, go through the concepts of bradycardias with the aid of diagrams, go through the examples, and finish with some Kahoot again at the end. Okay, so let's just stop share. So we'll go to Kahoot straight away. I'll just all right, here we go. You should all see that now. Loading up. So we'll get it coded, just there we go. You just turn off your mics if you're not asking a question, that would be great, thank you. Okay, so for those that have just joined, we're just doing some Kahoots. I'll just give you a minute to join in. You can only play this live. I don't think you can play it on the, if you watch this again.
What the fuck is going on?
Sorry? Okay, so if you don't want to play, that's fine. You can see the questions and the answers. I'm going to start now. Okay. Yeah, I think the answer is less than 50, really. Anything over 50 is probably okay. A lot of people quite fit and active these days, heart rate between 50 and 60, I wouldn't get too worried, but definitely less than 50 is much more likely to be pathological and, you know, perhaps an issue. So less than 50 be classed as a bradycardia. Yeah, so it means the sinus node is working. So just seeing P waves on its own, the sinus node is working during bradycardia. So we need to go through obviously the different causes and look at that. But yeah, that's what we see. If you see a P wave and there's a bradycardia, your sinus node is still working. Yeah, so therefore, if you don't see P waves, the sinus node is not working. There's one rhythm that's called junctional rhythm where you might not see a P wave, but we'll cover that in later on during the lecture. Yes, so we talked last week about the rhythm. It's very important when you go through your algorithm that you look at the rhythm and which one's irregular. So Wenke back block would be irregular, but complete heart block, fixed AV block, which is second degree AV block, Mobitz type 2, and first degree heart block, they're going to be regular rhythms. Whereas Wenke back block, you get progressive prolongation of the PR interval, and then the P drops, you don't get the P going to the QRS. And actually that would be an irregular rhythm, okay? Yeah, so it's a junctional rhythm, okay? So don't worry if you don't get this right. This is trying to introduce concepts to you, so don't worry. No P waves, a flat baseline would definitely be junctional rhythm. Yeah, so it's Mobitz type 2 heart block, okay? So in complete heart block, there would be probably more than 2 P waves for every QRS. When it's fixed, it's Mobitz type 2, 2 P waves for every QRS. Mobitz type 1 is what I said is another word for Wenke back block with prolongation of the PR interval and dropping. First degree heart block would be 1 P wave for every QRS, but there'll be prolongation of the PR interval. So we'll go through some examples, don't worry. It's going to be regular. So an escape rhythm means that the AV node is not working, depending how bad the conduction is from the AV node and the His-Purkinje system and the bundles, then the escape rhythm will either arise from below the AV node or distally at the His-Purkinje system, okay? It means that if it was pre-existing bundle branch block, it's much more likely an escape rhythm will arise from distally from the His-Purkinje system or the ventricular myocardium. But either way, if an escape rhythm originates from below the AV node or distally, it would always be regular. The escape rhythm is regular in complete heart block, always regular. Yes, so it's directly from beneath the AV node. So it's just below the AV node, as in sinus rhythm. The AV node doesn't work. So just below the AV node is the escape rhythm. So the beat that occurs very slowly, and it occurs directly beneath the AV node if it's a narrow complex. This is where we need to know when we're going through our algorithm, what's narrow and what's broad. I won't answer the next question. Excellent. Yes, so now you're understanding when it's an escape rhythm in complete heart block, the AV node doesn't work, but below the AV node doesn't work, and then all down the bundles it doesn't work. So it's very distal that the escape beat will happen. It's got longer to travel, and it becomes a broad beat, a regular broad QRS. Well done. Yep, so bifascicular, the word bi meaning two, fascicles, which we'll talk about, where they become blocked. So it's always right bundle branch block, but it could be axis deviation, either left or right axis deviation. And I took some time last week of talking to you about what is left and right axis deviation. If you add in trifascicular block, which is 3, you would add in a prolonged PR interval as well, okay? The reason why I'm telling you this is these patients with bifascicular block can develop complete heart block. So their resting ECG may show bifascicular block, but their dizzy episode or their blackout could have been intermittent complete heart block. So we'll go through that again in more detail, but it's trying to introduce the concepts. You understand a lot of things already. So the AV node came third. Delta wave came second. X came first. Well done. Okay. Okay, so let's just go back to okay. So again, I tried to show you this last week. Again, we're going through recapping. So we got the sinus node that beats first. Then it conducts in the atrium into the AV node, and this conduction into the AV node will signify the PR interval. And then beyond the AV node and down the His-Purkinje system is going to be our ventricular depolarization, and hence is going to be our QRS, traction of the ventricles. And already, as we get depolarization going down, repolarization will come behind it, and that will be measured from our Q to the end of our T wave. Okay, so it's interesting to see where the issues for bradycardia can arise. So we talked about axis last week, and that's very important at looking at left axis deviation, when that will be affecting the left anterior fascicle. I'll draw you a diagram in just a minute. And right axis deviation would signify in bradycardias the left posterior fascicle is affected. So the left bundle actually does split into two. One is anterior fascicle, one is posterior. So to recap, with left axis deviation, when our wave of depolarization going towards AVL is the most positive within the limb leads, you were looking at left anterior fascicular block. And at the same time, we should have negative deflections in 3, AVF, and 2. Alternatively, if we have right axis deviation, then 3 is going to be our most positive lead. The wave of depolarization is going towards the right axis, towards lead 3. Lead 3 is positive, and lead 1 and AVL will be negative. Right axis deviation is associated with left posterior block, left posterior block. So we remember, we're only looking at our limb leads when we're looking at the axis. Okay, so in this example, I said the most positive lead would either be 1 or 2. So then 1 or 2 is normal. So the wave of depolarization here is going towards 1 and 2. Okay. In this example, we're looking at the limb leads again. What is the most positive lead? It's AVL, yes, I agree. Lead 3 is the longest lead, but is negative. So the wave of depolarization in this example is going towards AVL. We have left axis deviation. We have left anterior block. And last and no means least, in this example, the most positive lead is lead 3. Lead 3 is positive. Yeah, let's check AVL and lead 1 are negative. Yep, they should be. The wave depolarization goes towards lead 3, and we have right axis deviation, which is left posterior fascicular block, left posterior fascicular block. So the other thing we talked about last week was the QRS being prolonged. So when you look at the ECG, you go through your rate, rhythm, axis, and intervals, you will see here that the QRS is prolonged and greater than 3 squares. Okay, so when you have a prolonged QRS, we probably have to start thinking about bundle branch block. That means at activation, there is no signal going down the left bundle, and it has to go to the right ventricle first, then the left ventricle. So the best place to start off is look at V1 and look at the signal in V1. We can see this is a negative deflection. So alone in V1, that would be suggestive of left bundle branch block. But let's check. The two things we can check for are, most of the time in left bundle branch block, there is left axis deviation. Yes, there is. AVL is the most positive lead. Also in left bundle branch block, it doesn't become positive until V5 and V6. So V2, V3, and V4 are negative deflections. That means they're below the isoelectric line. Okay, so this is left bundle branch block. And patients with heart block and dizzy spells and everything can have left bundle branch block as their resting ECG and go into complete heart block when the right bundle doesn't work properly. Alternatively, we have another ECG now where there is prolongation of the QRS. Okay, you can see this most marked in V1. As I said, look in V1, we now see that all the signals in V1 go above the isoelectric line. So if you see my cursor, this is the isoelectric line and it goes above. And you've got these bunny rabbit's ears now. In particular, you've got a small bunny rabbit's ear and a big one. That is indicative of right bundle branch block. It's positive. So how do we check we've got right bundle branch block? We go to AVL and we've got a slurring of the S wave there. And in V6, a slurring of the S wave again to suggest that this is right bundle branch block. In this particular example, the axis is normal. In patients with bifascicular and trifascicular block, there will be evidence of axis deviation, which I'll go through again just in a short while. So, sinus bradycardia. So sinus bradycardia means that the sinus node is working. It's working okay, but it's particularly slow. So in this example, we've got 1, 2, 3, 4, 5, 6, 7, 8, perhaps 9 squares between these two QRSs. That's 300 divided by 9 would be something like 33. And so in this example, the sinus node is firing. The PR interval is fine, suggesting that the AV node is fine every time the P wave, the sinus node fires, but it doesn't fire very regularly. So it's quite slow, but it's still a regular rhythm. So this is what we call sinus bradycardia with a rate of 33. Going now down to this example, so I'm showing you some examples now. So we can probably see that whether we've got a very flat baseline, but we haven't got any definite P wave here. Okay, so again, we have a bradycardia. We've got 1, 2, 3, 4, 5, 6, 7, about 8. So it's about 40, roughly 40 beats a minute. 300 divided by 8. We have a narrow QRS to suggest that our AV node is okay, but there are no P waves. Okay, there probably is a hint of something there that might be sort of a P wave. Okay, so really the P wave is probably buried in the QRS, and this is what we call a junctional rhythm. So the sinus node has stopped, doesn't work. The AV node, or the junction, as it's called, is taken over with a narrow QRS. Okay, so that's a junctional rhythm. Okay, when we get conduction that doesn't go into the AV node, first thing that we'll see is a prolonged PR interval. Okay, so you can see here from the start of the P to the beginning of the QRS, we've got a massively marked first degree heart block with about 360 milliseconds from the start of the P to the beginning of the R, and this is first degree heart block. Next, when the AV node gets a bit more stretched, particularly when there is high vagal tone, so some of us sleeping at night, there'll be evidence of this. So we clearly go across, there is the intermittent bradycardia, so it's not slow all the time. We do have an irregular rhythm. You look at the QRSs, but we have a PR interval that's slightly prolonged. The PR interval becomes more prolonged. The PR interval becomes more prolonged again, and more prolonged again until the P wave cannot conduct through. The AV node is too tired, and then it resets, and the P wave starts again going to the QRS. So this is evidence of your 2-to-1, your second degree AV block, but Mobitz type 1, or I call it Wenckebach heart block is the other term. This is also known as second degree AV block, Mobitz type 1. Now, when we look at the AV node being even more stressed, that it's so poorly functioning that we have a bradycardia again. We have a narrow QRS to say that the AV node, the rhythm is coming from either near or just below the AV node. We have P waves, so the sinus node is working, and the P wave is occurring, but nothing conducts, and the P wave conducts the ventricle, and the PR interval is okay on this beat. But the AV node is so poor, it doesn't accept the next P wave, and it has to reset again, P, QRS. Okay, so this is a really poor AV node, and certainly in this situation, you'll be definitely thinking about a pacemaker because the QRS is too slow and the heart won't be speeding up at all. And so this is second degree AV block. Okay, so just to recap, when we've got bundle branch block, in lead 1 being negative, below the isoelectric line with a broad QRS, we have left bundle branch block. In right bundle branch block, we have the opposite. We have a positive deflection above the isoelectric line. The bunny-rabbits here is a small and a big bunny-rabbits here, and that is right bundle branch block. Okay, so what happens if the AV node doesn't work properly? So if the AV node doesn't work properly and there's no conduction going in, we will have something called complete heart block. So electrically, the atrium and the ventricles are disconnected. There is no conduction getting through, okay? In most instances, if there is no disease of these bundles before this happens to the patient, then the escape rhythm can occur from this area just below the AV node, just at the bundle of His, and then depolarize down. So when we look at this example, we have a bradycardia, we have a QRS that's narrow, we have a regular rhythm as the spacing between every QRS is the same. Do we have P waves? Yes, we have P waves. So that means the sinus node is working. What is the relationship of the P waves to the QRS? Well, there is no relationship. Okay, there is no relationship. It's not 2-to-1 or 1-to-1. You can see the P wave is there. It's buried in the T there. P wave is there. P wave is there. There. Okay, so there's just no relationship at all between these P waves going along. So this is a narrow escape. So the escape rhythm's coming from up here. It's a narrow QRS. It's complete heart block. The patient will still need a pacemaker because the heart rate will be very slow. But this isn't quite an absolutely acute situation that it has to be done there and then because the QRS is narrow. So there's a bit of leeway. The patient will need to come in and have the pacemaker put in as an inpatient, but not quite as an emergency. Alternatively, if there is already been conducting system disease of the right and left bundles, and you get block of the AV node, so no conduction going down here, or no conduction going down here, then the escape rhythm has to come very distally from these areas, from the His-Purkinje system, and now we have a broad escape. The escape rhythm coming from here has to travel across, and that takes longer, and it becomes broad. So in this example, we have a bradycardia, 30 beats a minute, roughly. We have a broad QRS, that means it probably is it a broad escape? We've got a regular rhythm, so the escape rhythm is firing at regular intervals. Do we have P waves? Yes, our sinus node is working, and there is no relationship. The P waves occur, there's no relationship between these P waves and the QRS. There's one P wave buried in there. So this is a complete heart block now with a broad escape. And this patient's pacemaker should be put in pretty much immediately, whatever time of day they present. Okay, so just to move on now, when we have an irregular heartbeat called atrial fibrillation, you might associate atrial fibrillation with being a very fast heartbeat, and normally it is. So you do get very fast ventricular response, okay? So when the atrial fibrillation is occurring in the atrium and conducts the AV node, this will make the ventricles go very fast, but in particular, it will be in irregular rhythm because the atria are beating irregularly. The AV node is a 3D structure, so each depolarization is different to the AV node, but it conducts down, but it will be in irregular rhythm. When we slow the AV node down, perhaps with medication, or the patient may be older and their AV node may not be working properly, we can see now that we still have the irregular rhythm. We do not have any P waves, and there's a fibrillatory line there. So it's not a flat baseline, it's fibrillatory, okay? But we still have an irregular rhythm, and this suggests, although it's a bradycardia, so 1, 2, 3, 4, 5, 6, 7. 6 sevens are 42, so this is 42 beats a minute, and my maths is improving from last week. So it's an irregular rhythm, and so some of the AF is still conducting through. Some of the AF is still conducting through. Okay, so it's 42 beats a minute. It's irregular. The QRS is narrow. It's an irregular rhythm. So this is atrial fibrillation with slow ventricular response. It's going through the AV node still because it's irregular, but not very well. It's not fast. It's slow. So that might be medication or the AV node is poor. In comparison now, so when patient in atrial fibrillation, the AV node does not work, so none of the AF now conducts down to the AV node, we now will get a complete heart block. We will now see an escape rhythm. So now in this ECG, we can see that there's a bradycardia, 1, 2, 3, 4, 5, 6, probably 7 there. So again, 42 beats a minute. It's a bradycardia. What is the QRS? The QRS is broad. It's a regular rhythm now because the spacing between every QRS is the same. Are there any P waves? No, but there is a fibrillatory line here. It's not a flat baseline. There's fibrillation occurring in the baseline. So there's atrial fibrillation. And so now this is atrial fibrillation with complete heart block because the rhythm now is regular. So atrial fibrillation doesn't occur with a regular rhythm unless it's not penetrating the AV node and there is evidence of complete heart block. This is why when you do the algorithm, you're asking these questions all the time to try and give you an idea of what the answer is on the ECG. Okay? So again, we've gone through that. So thinking about our causes for bradycardia now. So just before I start, are there any questions at all? Okay. So it's worth thinking Okay, apologies there. What point did I go off? Hello?
Yeah, we can hear you.
Oh, you can hear me, thank you. Yeah. Okay, sorry, but I don't know which point I went off. I'm happily talking. So we talked about physiological, nocturnal, medication causes of bradycardia. The sinus node may not work properly, giving you sinus bradycardia. And also sinus node doesn't work at all, then the AV node will take over. The AV node is known as the junction, and we can have a junctional rhythm that ends up. It could be problems.
I don't think the slide is being shown. I think it does.
Sorry, thank you. Okay, let's go back. Okay, so we'll go through what was the broad QRS signifying in the Brady AF ECG. So that's an escape rhythm. That's the escape rhythm from the distal, his Purkinje system, very broad QRS. Okay, and we're just starting on the causes for bradycardia now. So I'm just trying to load up the PowerPoint. Okay, so we talked about physiological. Is the QRS narrow? It would be proximal escape. Yeah, if the QRS was narrow, you got proximal escape just below the AV node, so it conducts down his Purkinje system like that. If you're looking at me, so it's going to be a narrow QRS. Yeah, good question. Okay, so causes for bradycardia: physiological. You might be fit and active, nocturnal at night. 40 is fine. No problem. You're welcome. Nocturnal is fine. Medication can obviously slow conduction through the AV node, causing a bradycardia. It also slows the sinus node as well. So if you have a problem with the sinus node, then obviously then we can get sinus bradycardia. As I've said, the sinus node doesn't work at all, then we can have a junctional rhythm. The AV node is also known as the junction. The sinus node doesn't work, and the AV node can take over, and the sinus node, that will be a narrow QRS signal. If the AV node doesn't work, then obviously then we might have a prolonged PR interval. Depending how bad the AV node works, it might be Wenckebach, it could be second degree, maybe it's type 2, or it could be complete heart block where the AV node doesn't work at all. So I've sort of alluded to that with the bundle of His. There can be pre-existing conducting system disease, such as left bundle branch block or right bundle branch block with either bifascicular or trifascicular block. I'll talk about that in more detail in a minute. Okay, we've talked about the concepts of sinus nodes, sinus bradycardia junctional rhythm, conducting system disease, where they may have no symptoms. This could be first degree, left and right bundle branch block, bifascicular, trifascicular block, an AV node, and complete heart block. Okay, so what I'm going to do is trying to go through things now and explain them sort of pictorially to you so you can understand in a bit more detail. So let's start off with sinus nodes. So this is the drawing of the heart, so a little simplified drawing. There's the sinus node, there's the AV node. So what happens if our sinus node is slow? Obviously it comes out slowly. Sorry. Okay, thank you. Right, so if our sinus node doesn't work properly, then obviously then may get, Right, so sinus node doesn't work properly. So you get sinus bradycardia. It doesn't penetrate out properly through the atrium. So it might be a slow heartbeat, but you will still see a P wave. So sinus bradycardia, the sinus node is still working. If the sinus node doesn't work at all, then we're lucky to have the AV node to take over. So if the AV node takes over, we have the right bundle, and then we have the left bundle. Okay. And if our AV node beats as a pacemaker, as it does, you're going to have a narrow QRS penetrating down that way when the sinus node doesn't work. So now if we come to the ECG during this situation, so you have a narrow QRS, okay, on the ECG, and we have a regular rhythm. So this is the AV node firing off, AV node firing off. Our baseline is going to be very flat, okay, just have to bear with me. Our baseline is very flat, okay, and this is the AV node firing off. But if the AV node fires off and the sinus node doesn't work, it will go backwards to the atrium. So you do get this conduction of the AV node going backwards this way and this way down to the ventricle. So this way round to the ventricle is being signified by these QRSs. And so going back to the atrium, there may be some P waves. So the firing of the P wave might be evident, it might not. The P wave going back to the atrium could be there. It could be at the end of the QRS, or it could be buried in the T wave. There's three areas. So now we put those together and see what can you see on an ECG with junction rhythms. So the junction beat could just be a narrow QRS like this, okay, and you wouldn't see a P wave. Or if we bring these two beats together, it could be a QRS that's still narrow. And it might be that the P wave is just after the QRS, okay? So we're putting this together now. This is the escape, the backward beat from the AV node to the atrium. This is the QRS going on the AV node. So that would still be a junctional beat with a P wave afterwards. Or you might even see it in the T wave. So let's just draw a T wave, and there's a little bump in the T wave. Again, this would still be a junctional beat. So you can see the T wave is abnormal, it's not flat. This is now your retrograde activation here, going back to the atrium. This is your retrograde activation going here, back to the atrium. Your activation is still occurring, but you don't see the P wave because it's buried in the QRS. So this is what we call a junctional rhythm. So you may or may not see a P wave. Any questions about that? Okay, good. So just going back. So the next thing we'll talk about is the AV node. So I said to you about the AV node, if you have first degree heart block, then it's difficult to get in here. It's slow going into the AV node, so I'll put a little X there, slow going into the AV node, but everything else is okay. So right bundle, left bundle, sinus node is okay. So then we just have prolongation, the P going into the QRS, the narrow QRS is prolonged. Okay, so we have a long heart block. So let's just put a little bit of a concept in there. Let's say we've got first degree, but then we cause some delay in this right bundle. So that's how I put delay now. So I have delay going down the right bundle. There is right bundle branch block. What would we see then? So if we have right bundle branch block, so I'll say R, and we're looking at lead V1. Okay. If the P wave comes after the QRS complex in a junctional rhythm, would it be difficult to differentiate it from a T wave? Yes, it might be. It might be difficult, but in actual fact, the algorithm allows for you not seeing a P wave. When I come to you look at the algorithm, if you don't see a P wave, but you have a flat baseline, you should think of a junctional rhythm. Okay, but sometimes you might actually, if you look hard enough, see a P wave. So I will show you some examples later on. Good question. So the R with right bundle branch block in V1, we're going to have, you're welcome. You're going to have now a prolonged PR interval. But in V1, remember, we're going to have the bunny rabbit's ears and a broad QRS. Okay, so that's with right bundle branch block in the presence of prolonged PR interval. Is everyone happy with that? So this is right bundle branch block. In V1, we have the bunny rabbit's ears. We've still got the prolonged PR interval, which is signified by conduction not getting into the AV node this way, but there's delay around here, so it's got to go this way first and then across. That's just trying to show you the concept of first degree heart block. Okay. Okay. So let's talk about bifascicular block then, as we're talking about right bundle now. So what does this mean? So again, we've got the right bundle. Draw this colour. So we've got the left. So this is called the left posterior fascicle. This the left bundle is actually split into two. And then you have to think of this in 3 dimensions. It's coming forward. This is the left anterior fascicle. Got the right bundle there because it's going to the right. Let's put an R. Okay, so with bifascicular block, so bifascicular, I'm going to put bi here. We have 2 things going on. Okay, so we always have in bifascicular or trifascicular block, the common denominator is right bundle branch block. Okay, right bundle branch block, RBBB. Okay, so I signify that by doing this. This is right bundle branch block. Then what happens first for bifascicular block is that there is axis deviation. So if there is left posterior fascicle block, as I mentioned earlier, we're going to have right axis deviation here. Okay, you look at the ECG, you have right axis deviation. So bifascicular right bundle branch block plus, so it's right axis deviation. Bifascicular block plus, sorry. Okay, so if that will be blocked, and the patient then on this bit, this is blocked. This patient is living on their left anterior fascicle as the only remaining fascicle that's perfect, is okay. So something happens to them, and then this blocks off in this situation. So the conducting system disease. So now you can understand that there's no conduction through. This has become blocked. And so this is the patient that will have the very distal escape rhythm from either here, escaping, if they go into complete heart block, or over here, escape rhythm happening. So when this happens, complete heart block in bifascicular block, they have a broad escape rhythm. So the QRS can be very broad as an escape rhythm, rather than being a narrow escape rhythm if it was escaping from just below the AV node. So that's just an example. So that's bifascicular block when there's right axis deviation. So let's just go a step back. If there is left axis deviation now on the ECG, let's go a step further back. Ooh, too far. So bifascicular block. Now again, you have right bundle. And this time, if we take out our left anterior fascicle, take out our left anterior fascicle, we will have left axis deviation on the ECG. Left axis deviation, as well as the right bundle. purple. Yep, so left axis, we've got now delayed. So this patient is slightly different. They're just living on their left posterior fascicle now. Okay, they're okay. They've got right bundle plus left axis deviation. That's two things bifascicular block. So they're living on the left posterior fascicle. One day it happens that this suddenly doesn't work properly. They go into complete heart block. No electricity can go anywhere down. So again, they have an escape rhythm that's coming from very distally here or distally there. And again, same way, we'll have a broad QRS morphology because it's a broad escape coming from distally. Okay, so they're the two things you look for in ECG. So at one point, the patient's fine. They got the resting bifascicular block. Then something happens. They go into complete heart block. They have a broad escape rhythm, which is regular and broad. Then just to mention, if we talk about trifascicular block, and that I will repeat the whole process. Trifascicular block means right bundle, left axis, or right bundle, right axis, if it's this fascicle. But the trifascicular block, we add in that going into the AV node is not very good. So remembering what means going into the AV node is first degree heart block. So first degree heart block in addition. So that makes it tri. Three things are wrong. First degree heart block, right bundle branch block, and left axis deviation. Any questions about bifascicular or trifascicular block? Okay. So the next thing we'll talk about is the AV node not being very good when the conduction is fine in the distal territory. So there's a question. Are the fascicles just the bundles then? Yeah, so it goes AV node, then obviously then the bundle of His, and the right bundles, yeah, they're the fascicles. Okay. Should there technically be an anterior bundle of His too? Anterior bundle of His. No, the left bundle splits into an anterior fascicle and posterior fascicle, if I'm understanding the question correctly. Then you've got the right bundle. The right bundle is on its own. That's just a single entity. Whereas the left bundle, if you look at it, then you have the left posterior fascicle and the left anterior fascicle. Okay. So, how far back? Right, so let's go back to just having no worries, you're welcome. Okay, so if there's a problem with the AV node, I talked about how bad the AV node is, will tell you whether there's some function of the AV node, but it's very slow. So first degree we've talked about. Wenke back, you have to imagine that there's prolongation of the PR interval at every beat. When the AV node doesn't work very well at all, you get two P waves occurring. So one won't go. And the AV node hasn't recovered yet, then the second one comes along. So number two gets through. Number one doesn't get through. Okay. So obviously imagine then you've got P wave, and P wave does get through. They narrow QRS because we know that the right and left bundle are okay. So in actual fact, you could probably do it like this. So there's your P wave is purple. The first one doesn't get through, the AV node's not recovered. The second one gets through fine. And then your P wave sinus node fires again. The P waves are always regular. Sinus node fires, AV node hasn't recovered, and it takes the second one again to come along. This one is okay. This one does conduct through. And so this is what we call fixed AV block. So it's fixed. The number of P waves to the QRS is fixed at 2 to 1. but it's second degree AV block, Mobitz type 2. Okay, so an indication for a pacemaker here. And the QRS is narrow, because obviously we're saying that the bundles are okay, the escape's coming from just below where the disease is. So the disease is very specific for the AV node, but the escape rhythm is coming from the bundle of His, which is just below the AV node. Okay, so hopefully that explains pictorially for you. So this is the diagram of my algorithm. And so for bradycardias, it should work that you start off, okay, with your first question. You defined it's a bradycardia, and you probably heard me talk about it and the steps that you need to do as you go through it. Is the QRS narrow or is the QRS broad? So that would give you some idea about if the QRS is narrow, the AV node might be okay, or the escape rhythm's coming from just below the AV node. If the QRS is broad, then you're thinking, could this be bundle branch block? Could this be an escape rhythm that's coming distally and it's not below the AV node because it could be a complete heart block? Okay, so that's that question there. You ask yourself that question. The next question you ask yourself, is the rhythm regular or irregular? Now in this example, because this has been looked at by experts, when we look at Wenckebach block, which probably is irregular, so you can answer Wenckebach block being irregular, you might think it's got some sort of pattern that makes it regularly irregular, and we'll look at that. So you can get to Mobitz type 1 or Wenckebach 2 ways. So you can't, if you think it's irregular, fine, you'll get the answer. If it's irregularly irregular, you'll still get to Wenckebach Mobitz type 1. Okay, so is the rhythm regular or irregular? So if it's irregular, we think it might be atrial fibrillation. It might be atrial fibrillation, okay, because if it's still conducting through the AV node. The next question is whether there are P waves. Is our sinus node working or not? So if there are P waves and it's an irregular rhythm, we probably have Wenckebach block. If it's an irregular rhythm with no P waves, then we've got to think it's irregular. So there's AF conducting through, but there's a slow ventricular response. If the rhythm is narrow, regular, with no definite P waves, there are two things it can be. Now, the no definite P waves means that the baseline is flat and the P wave or there's a P wave buried in the QRST, then we have a junctional rhythm. The AV node is taken over, the sinus node is not working. Or if we have a wavy baseline and it suggests fibrillatory activity, best seen in lead V1, by the way, then we have AF with complete heart block, because there's been a regular rhythm with no definite P waves, wavy baseline, AF with complete heart block. And now down this side, if we have a QRS that's narrow, regular, with P waves, our sinus node is still working. What is the relationship of the P waves to the QRS? So is it 1-to-1? Is it a sinus bradycardia? Or is it first degree heart block, depending what the PR interval is? If it's typically 2-to-1, but more than P's than QRS's, then it could be Wenckebach still, or Mobitz type 2, second degree AV block, Mobitz type 2. So there's normally 2 P waves for every QRS. Or if there's no relationship of the P waves to the QRS, then we have complete heart block. Okay, so that answers your bradycardias that are narrow. If we go over to the side that's broad, there's less of these. So we're looking at, again, ask yourself the question, is the rhythm regular or irregular? Are there any P waves? Okay, so if it's a regular rhythm with no P waves, it could be. So hyperkalemia can present with a bradycardia, hyperkalemia, and you will see tented T waves. Otherwise, if it's a regular rhythm broad and there are P waves, and the relationship now of the P waves to the QRS, so it's a 1-to-1 relationship. We could have sinus bradycardia with bundle branch block, it could be right or left, or if the PR interval is prolonged, we could have sinus bradycardia with first degree heart block, bundle branch block, because the QRS is broad. QRS broad, regular rhythm, P waves, relationship with the QRS, you could get Mobitz type 2 fixed AV block. It's less likely you get second degree AV block with broad QRS, because as I sort of explained to you, they're more likely to go into complete heart block. So you would have P waves, but no relationship to the QRS. If your rhythm is broad, regular, no P waves, then you have AF with complete heart block. And in particular, between every QRS, you will have fibrillatory wavy baseline, signifying atrial fibrillation in the atrium, best seen in lead V1. Lastly now, QRS being broad and irregular, you would have conduction through, so atrial fibrillation still conducting through with a slow ventricular response, but a bundle branch block pattern, typical bundle branch block pattern. And also you can get a bizarre QRS that's irregular this time. And again, it could be tented T waves with hyperkalemia. These two can present either regular or irregular. They can also present with slightly tachycardia as well, which I'll talk to you about a couple of weeks' time. Any questions about the algorithm? Okay, so let's go through some examples then. You want to use the algorithm and practice. I'll just give you some time to look at the ECG and then we'll walk and talk through all the examples. So, do we have a bradycardia? They're all bradycardia. So 1, 2, 3, 4, 5, 6, 7. 6 7s are 42. So that by definition, that's a bradycardia. Is the QRS broad or narrow? This is a narrow QRS. That means our AV node might be okay, or the escape rhythm's coming below the AV node. Are there any P waves? Yes, there are P waves before every QRS, so the PR interval is okay, the AV node is okay, but the issue is here that this sinus node is not firing. It's very slow. It could be physiological, it could be medication, it could be recorded at night. So this is a sinus bradycardia, sinus bradycardia. So concentrate on the bottom rhythm strip. Okay, so I'm not going to talk you through this because it's quite challenging. So if you look at the rhythm strip, you ask yourself what is happening and what is not happening when it should happen. Okay, so perhaps the algorithm doesn't allow for this rhythm actually. So what you can see here is that you have a P wave, that's just a T wave. You have a P wave, so you have a bradycardia 1, 2, 3, 4, 5, 6, 7, 8, 9. So relatively 54 beats a minute. Basically, the sinus node, it's an irregular rhythm. Well, it does seem to be slightly regular. Irregularly. And there are P waves firing off going to the QRS. So the PR interval is okay. The AV node is okay. And what else about this ECG tells you the AV node is okay is you've got a tachycardia recorded at this point in time. So don't forget, ECGs will be recorded these three first, then those three, then those three, and those three. So there's a different time point. Then the rhythm strip comes last. So you can see that there is P wave firing off, but the P wave should fire off here, but it doesn't. It takes a while for the sinus node to then fire off. Okay, so this means that no signal is coming out of the sinus node. And this is an example of sinoatrial exit block or a mixture of tachy-brady syndrome. So the AV node is fine. When the patient goes into atrial fibrillation, the heart's very fast, there's tachycardia. But when the heart goes back into a normal rhythm, the sinus node is very slow and they have a bradycardia. So you can imagine these patients present with dizziness, blackouts. You certainly could do with a pacemaker to help their sinus node to speed it up. And then they can safely have medication to stop it going fast. So this is sinus bradycardia, but a form where the sinus node is not firing, okay? It perhaps can't be covered in the algorithm, or we haven't covered it. Okay, so sinus bradycardia, tachybrady syndrome, sinoatrial exit block for that one. Okay, this is a good example. I'll just give you some time just to look at this, please. So do we have a bradycardia? 1, 2, 3, 4, 5, 6, 7, 8. 6/8 is 48, so we do have a bradycardia. So is our QRS narrow or broad? Our QRS is definitely narrow. The AV node is okay, or the escape rhythm's coming from below the AV node. Okay. Our rhythm is regular, so whatever's happening with the QRS, it's a regular rhythm. Okay, spacing between the QRS is the same. Are there any P waves? Well, okay, if you say no, there are no P waves, you've got a very flat baseline. It's extremely flat. So by looking at your algorithm, okay, you should come up with an answer of junctional rhythm. There's no P waves in there. However, if you look carefully, I understand this lady's coming with chest pain. She has got T wave inversion anteriorly, but you can see that this is a P wave. That T wave is is bumpy, not smooth. And there's a P wave there. There's a P wave there, there. And you can see now in the T wave on lead 2, this is a P wave within the T. So this is your retrograde activation back to the atrium from the AV node. And it's negative inferiorly. It's going backwards from the AV node back up to the top. So this is your retrograde P wave, but the algorithm allows you not, if you don't see that P wave in the T wave, you still get the answer of junctional bradycardia, junctional rhythm. Okay, so that's a junctional rhythm. Have a look at this one, please. Okay, so perhaps having looked at the last one, so we have a bradycardia 1, 2, 3, 4, 5, 6. Okay, we have a bradycardia. We've got 36 beats a minute. That's slow. I think the QRS is narrow. It's less than 3 small squares here. Okay, the spacing between every QRS is the same. So we have a regular rhythm. It's regular. Are there any P waves? Is it hard to see them? There's certainly no P waves before the QRS. The baseline is exceedingly flat everywhere. And this is probably another example. So there is probably your P wave now. You can probably see the P wave nicely in V1. That's your P wave, that's your retrograde activation back from the AV node to the atrium. And then there's your T wave, which is okay. There's probably another bump in there. Again, if you didn't see the P wave, your answer would still be flat baseline, P wave or not, and a junctional rhythm again. In actual fact, you can see this example, there's another P wave there buried in, retrogradely activating the atrium. Hence, again, this is a junctional rhythm. Okay, just please shout out any questions if you want. I'm going to plow through and go through them, work through them all with you. You can actually pause them again if you want to watch this video again. So again, I think the advice is with bradycardias is to use the rhythm strips. The rhythm strips are quite helpful. So again, you've got a bradycardia on this example. The QRS is narrow, so perhaps our AV node is okay. Spacing between every QRS is the same. We have a regular rhythm. Okay, are there P waves? Yes. What is the relationship of the P waves to the QRS? There is a prolongation here. It's just evidence of first degree heart block greater than 1 large square. So it'd be a mixture of sinus bradycardia. It's just 1 P wave for every QRS, but a mild first degree heart block, about 240 milliseconds there. This is first degree heart block and sinus bradycardia. So again, we're going to think of this as a continuous rhythm strip along here. I'll just give you some time to look at this and just see what you think. Okay, so it seems a strange one, but so we've got a P going to the QRST and then a P. So the one way to look at this is try to go along here and just see P, QRST, P, QRST, P, QRST, P, nothing. Okay, So if you look at this ECG, it is probably an intermittent bradycardia. So it's not always bradycardic. There is an intermittent bradycardia. Okay. The QRS is narrow. So perhaps our AV node is not bad, or there's an escape rhythm again. Are there any P waves? There certainly are. So the sinus node is working. What is the relationship of the P waves to the QRS? So as you can see, your rhythm might be irregular. You might say it's irregular. But in actual fact, if I look at this, I sort of see some sort of pattern. And so you could say it's regularly irregular. So either way, the algorithm allows for you to get to an answer, because it's difficult to say, you know, that perhaps this is irregular, or it might be regularly irregular. It's certainly not regular on its own. Okay, so you can see that you have the PR interval that's okay. The PR interval gets longer here. AV node is being stretched. It can just about take it. Yep, AV node's okay still, but taking it's harder. AV node is stretched again longer. P wave, AV node can't take the P wave, drops. Reset, the AV node now resets itself. P, QRS is okay, longer again, longer again, longer again, drops. P wave doesn't go to the AV node. Okay, it starts off again, P, QRS, T, it gets longer. So this is your evidence of your Wenckebach block, or your second degree AV block Mobitz type 1. So it's not quite so dangerous. It can be related to high vagal tone. You probably wouldn't pace for this on its own, but it may be a sign that they may be progressing to further degrees of block in the future. So that was Wenckebach block Mobitz type 1, second degree AV block Mobitz type 1. Okay. So this example 1, 2, 3, 4, 5, 6, 7, 8. So we have a bradycardia. So we've got a 48 beats a minute bradycardia. So let's use our bradycardia algorithm. We have a QRS that's narrow. Okay. We have the spacing between every QRS is exactly the same. So we have a regular rhythm. It's a regular rhythm. Are there any P waves? Yes. There's one. There's another one. Okay, there seems to be some pattern here in the fact that there is 2 P waves for every QRS. 2 P waves. Okay, this means that this P wave doesn't conduct through, no QRS. AV nodes recovered, P, QRS, T. Okay, that's okay. The AV node is poor again, doesn't conduct through that P wave, and then there's another P wave going through QRS. Okay, so this is an example of second degree AV block, Mobitz type 2, or it can be sometimes called fixed AV block. So it's fixed as in 2 P waves for every QRS, 2 P waves QRS, 2 P waves QRS. 2-to-1 AV block is another way of saying this. But certainly this patient's rhythm is going to be very slow. They're going to need a pacemaker. So why are there no T waves in that example? Are we talking about bradycardia 7? Yeah. So no T waves in that example. Yeah, I mean, there probably are. You can see that there is a T wave. You've got a T wave, there's the T wave. And at the end of the T wave is the P wave there. Another P wave. So if you got a piece of paper and mapped out the P waves would be regular. They would map out exactly. The sinus node just fires, keeps firing. The AV node is so poor, it only allows the second sinus beat to go through. Yeah, so there are T waves along here. They're just very flat. Not, you know, so there may be a bit more history to this about why this patient's got, you know, flat T waves or inverted T waves. I hope that answers your question. There's still T waves. So this is Mobitz type 2 second degree AV block, or fixed AV block. 2-to-1 AV block is another thing that can be explained. Okay. So here's another example. 6, 7, 8, 9. So it's roughly a bradycardia, intermittent bradycardia. I just put it in as an example really to show you. So we have a broad QRS, so certainly greater than 3 small squares. Okay, we do have an irregular rhythm. Again, the algorithm may not allow for this. We do have P waves before every QRS, so you can check P, QRS. Every time there's a P wave, there is a QRS, but there is a broad QRS. In particular, it's negative in V1. Okay, so below the isoelectric line makes you think of left bundle branch block. It doesn't become positive till V5 and V6, although in this example, the axis is normal. So there's evidence of left bundle branch block. The PR interval is okay, but what you can see is the sinus node is the problem. Sinus node fires, it should fire again, it doesn't. And the sinus node doesn't fire, right there it fires. This example, you can see the P waves a bit more. Again, there's a pause, sinus node fires, delay, fires. So this is an example of sinus bradycardia, sinoatrial exit block in the presence of left bundle branch block. Left bundle branch block. Okay, so again, 1, 2, 3, 4, 5, 6, 7, 8. So 48 beats a minute. Is the QRS narrow or broad? The QRS is certainly broad. Okay, so let's go up to V1. It's broad. We can see a negative deflection. Yeah, okay, negative there. There is left axis deviation. It doesn't become positive till V5 and V6. Okay, that tells me this is left bundle branch block, or it could be an escape rhythm that's coming from the right ventricle. Okay, so you don't know that for a fact at the moment. Are there any P waves? Yes. What is the relationship of the P waves to the QRS? Okay, so it's prolonged. So there is a one-to-one relationship of the P waves to the QRS, but it's a prolonged PR interval. So this is not an escape rhythm. This is left bundle branch block with prolonged PR interval. So the AV node getting into the AV node is poor, and there's delay in activation on the left bundle, giving you left bundle branch block. First degree heart block and left bundle branch block. Okay. So, okay, no rhythm strip here, and not really a bradycardia, but I wanted to show you this as an example. Okay, so it's a very subtle change showing bifascicular block, so resting bifascicular block. So the heart doesn't have to be slow at this point in time, but there is a chance for this patient to develop block in one of the other fascicles going into complete heart block. So if we go to V1, we can see if we used our basic algorithm, the QRS is broad. There's a tiny bump here, okay, tiny bump first and a bigger bump. Okay, that means it's positive. It's above the isoelectric line, so this is right bundle branch block. In particular, there is a negative deflection in 2, very negative in 3 in AVF, and AVL is perhaps the most positive. So you can have left axis deviation with right bundle branch block is bifascicular block. The PR interval is probably just okay in the normal range. This is not trifascicular. This is therefore bifascicular block, right bundle and left axis deviation. Okay, if you want to glance at this one, there is quite a few things going on here really on this example. So again, we go to the rhythm strip. You can see 1, 2, 3, 4, 5, 6, 7, 8. So the heart rate's 48 beats a minute. There is a broad QRS. It's a broad QRS. What does that mean? Is it bundle branch block or is there an escape rhythm? So that every time there's a P wave, there is a QRS. P wave, QRS. P wave, QRS. Okay. The PR interval might be verging on first degree heart block. So let's go up to V1. Let's see, we've got a very small bunny rabbit here, and a big one. Okay, it's broad. We have a slurring in the S wave here. So we have right bundle branch block. It's arguable whether there's a first degree heart block, but I think there probably is. The QRS is starting here. So we have first degree heart block. Let's look at the axis. Yeah, AVL is the most positive lead. We have left axis deviation. So this is an example of sort of everything put together. So we've got first degree heart block. We've got an irregular sinus node. The sinus node is firing very intermittently. The sinus node isn't good. The AV node isn't particularly good. And there's bundle, right bundle branch block and left axis deviation. Okay. So, if this patient was dizzy, they may get complete heart block with a very slow sinus node and definitely need a pacemaker. The question is, so sorry, why is there right bundle branch block? In this example, bradycardia 11. So you've got a broad QRS. If you used your basic algorithm, you would come up with a QRS being broad. It's greater than 3 small squares. So when you have that, you go to V1. V1 is positive. Above the isoelectric line is the QRS. So the start of the QRS is there. End of the S is there, and there's our T. So it's definitely a broad QRS, and you've got this little bump that comes first, and then a big bump afterwards in V1, suggestive of right bundle branch block. In addition, you have left axis deviation, prolonged PR interval, and a sinus node that's got sinus bradycardia, sinoatrial exit block. There's a lot of things going on there. No worries, you're welcome. Okay. Okay, moving on. Nearly got through the examples, and then we'll do a little bit of testing if you want to stay on. Okay, so again, we have another bradycardia. So let's use our rhythm strip again. So 1, 2, 3, 4, 5. Blimey, this is really slow. 30 beats a minute. Okay, our QRS is definitely narrow. Yes, I can see that the end of the T goes there, definitely. So our QRS is narrow. When the QRS occurs, it's a regular rhythm, regular, okay? Regular. Are there any P waves? Yes, the sinus node is working. Is there any relationship with the P waves to the QRS? No, the P waves fire off. They fire independently of the QRS. So there is no conduction going through the AV node with these P waves. It's just firing off. No relationship. There's another one. And this is complete heart block with a narrow escape rhythm. Narrow escape rhythm. Okay. Yes, the T wave is very prolonged. You might think this is a really prolonged QT interval, but for the given rate, it might not be too bad. This is actually a patient that had a pacemaker put in that was taken out. So they've got these things called T wave memory changes. We're not too alarmed by this. They're waiting for have a new pacemaker put in. So just to recap, we have a narrow QRS. So the escape rhythm is coming from just below the AV node. And this is congenital complete heart block. There are P waves, the sinus node is working, but now there's no conduction from the sinus node to the ventricles. So this escape rhythm is just enough, 30 beats a minute, regular, keeping the patient alive before they have a pacemaker. Number 13. So have a look at our rhythm strip along here. Okay, we have a bradycardia, 1, 2, 3, 4, 5, 6, 36 beats a minute. Okay, we have a broad QRS, greater than 3 small squares. So we think about bundle branch block, or we might think about an escape rhythm coming from the distal ventricle. Okay, are there any P waves? And the rhythm is regular. So if it is an escape rhythm or a bundle branch block, it's firing regularly in the ventricles. Are there any P waves? Yes, there are P waves, and there's no relationship with the P waves. So there's a P wave in there. There's no relationship with this P wave. There's probably a P wave buried in here. You don't see it. It should be timing there. Then you see a P wave. There's a P wave. These are firing regularly. You see as I go along, it's the same distance. So the sinus node is firing, but it's not penetrating to the ventricles. There's no association of the P waves with the QRS. So this is complete heart block with a broad escape rhythm. Now, some of you may have noticed, oh, okay, look at this. This looks like left bundle branch block. And there's left axis deviation. It doesn't become positive greatly until V5 and V6. So this is an escape rhythm that's coming from the right ventricle as if there is left bundle branch block. It gives the same sort of pattern. So if there was an escape rhythm coming from the left ventricle, it would be a right bundle branch block morphology. So this example is complete heart block with a broad escape rhythm. Okay, this is so let's take this as one long rhythm strip for the purposes of the teaching. So we have a bradycardia. We have a rhythm 1, 2, 3, 4, 5, 6, 7. So 42 beats a minute. Okay. The QRS is narrow. So perhaps the AV node is okay, or there's an escape rhythm coming from just below the AV node. The rhythm is irregular. spacing between every QRS is variable. And if you look in V1, it's not very flat. There's some sort of baseline, wavy baseline there, suggestive of atrial fibrillation, best seen in V1. Not always, but mostly seen in V1. So there's atrial fibrillation occurring. It's still conducting through as an irregular heartbeat, still conducting through. So this is an example of atrial fibrillation with slow ventricular response. So the AF is still conducting through as evidenced by an irregular rhythm. Okay. AF with slow ventricular response. Okay. So next one here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's 60 beats a minute. So on the cusp of being a bradycardia. We have a narrow QRS. Spacing between every QRS is exactly the same. We have a regular rhythm. Are there any P waves? No. But we go to V1 now, you can see what's going on now. You have this fibrillation. Okay, you see it in V1, V2, V3, perhaps also. There's not a flat baseline anymore, so this suggests there's atrial fibrillation. But in atrial fibrillation, you shouldn't have a regular rhythm. Should you? You don't get atrial fibrillation. If it conducts through, it will always be irregular. So because you've got a regular rhythm, you've got atrial fibrillation occurring in the top chamber. It's not penetrating down to the past the AV node. And therefore, we have a regular, narrow escape rhythm in this example. Okay, the rate is 60, borderline bradycardia, but this is AF with complete heart block with a narrow escape rhythm. Narrow escape rhythm. Okay, nearly done. On to 16. So a bit more tricky. So we have a possible bradycardia 1, 2, 3, 4, 5, 6, 7, 8, 9. So 54 beats a minute. So borderline bradycardia. We have a QRS that's definitely broad. Okay. We have an irregular rhythm. So the spacing between every QRS is variable. Okay, this might suggest that there's atrial fibrillation. Again, the baseline is wavy here to suggest that there is atrial fibrillation. And it is conducting through to the ventricle as evidenced by the QRS, but the QRS is irregular as you'd expect in atrial fibrillation. It's not conducting through very fast. We go across to the V1 because our QRS is broad. It's a negative deflection below the isoelectric line. This is evidence of left bundle branch block. Okay, so this will be evidence of atrial fibrillation, slow ventricular response, left bundle branch block pattern. Left bundle branch block. Okay, so bradycardia 1, 2, 3, 4, 5, 6, 7, 42 beats a minute. So bradycardia. The QRS is definitely broad. Broad QRS. If it's broad, we go up to V1. Yep, we can see that there's a broad, it looks like a left bundle branch block pattern. Okay, are there any P waves? I don't think there's any definite P waves. In actual fact, if you look at this baseline, it's not flat, it looks wavy. Okay, let's look at V1, yeah, it's wavy. V2 is wavy. So there's atrial fibrillation here occurring, but we have a broad escape rhythm. Because AF should conduct irregularly if it's going through the AV node. But in this example, the spacing between the QRSs is exactly the same. It's a regular rhythm. So this is atrial fibrillation with complete heart block and a broad escape. Broad because the QRS is broad. And because this is left bundle branch block pattern, it's coming from the right ventricle, the escape beat. Okay. So this is really a spot diagnosis, really. It's a very bizarre looking, irregular ECG. It's a broad QRS, very bizarre looking. Doesn't really fit the bundle branch block pattern at all. And the T waves are very tented here irregular rhythm, so different beat there, no P waves, tented T waves, and this is your example of your hyperkalemia. So it doesn't fit any bundle branch block pattern. Tented T waves, no P waves. This is hyperkalemia. So I just thought I'd show you just some examples of obviously treatments of patients. So when we put pacemakers in, pacemakers can either go to pace the atrium, if obviously the sinus node is not working properly, or we'll pace the ventricles. So in this example, it's very interesting. There's only a single chamber pacing. This is a pacing spike with a broad QRS, suggesting this is pacing the ventricles. Pacing spike, broad QRS, it's pacing the ventricles. So this patient has a single chamber device. It's only pacing the ventricle very slowly at this point in time. You can still see the P waves that are not associated with the pacing at all. So they are still dissociated. So the sinus node is doing its own thing, but the pacemaker is firing off at a slow rate. Okay, pacemaker, broad QRS. So this is a single chamber ventricular pacemaker. Single chamber ventricular pacemaker. Compared to this example, where now you have dual chamber pacing because of a pacing spike and a very small P wave. See the P wave is negative there. So another pacing spike. And now you get association between the P waves and the QRS because you then got a pacing spike and a broad QRS. Pacing spike, broad QRS. So we've got pacing in the atrium, P wave, very small one. Pacing again in the ventricle, broad QRS, which signifies the ventricle. So this is dual chamber pacing, dual chamber, both the atrium and the ventricles. Okay, so remember that we talked about the sinus node, evidence of sinus bradycardia junctional rhythm. There may be evidence of conducting system disease. So at that point in time, they may have no symptoms, but could develop symptoms. So this might be first degree heart block when there's left bundle branch block or right bundle branch block. We discussed about bifascicular block when you've got axis deviation in association with right bundle branch block, and trifascicular block when there is first degree right bundle and axis deviation. The AV node might be particularly poor, and there could therefore be evidence of fixed AV block or second degree AV block, Mobitz type 2. So there you'll typically see 2 P waves AV QRS. When the AV node does not function at all and there's complete heart block, there may be P waves if the sinus node is working, but no association of the P waves with the QRS. And lastly, there could be atrial fibrillation with complete heart block, where we're looking at a wavy baseline. Okay, any questions? Yeah, so bundle branch features, you've got a broad QRS, you should go to V1 and see whether there's right or left bundle branch block. Obviously, left will be below the isoelectric line, and above the isoelectric line will be right bundle branch block. You're welcome. Okay, so if you want to stay on, and I'm going to do some Kahoot again. Just want to hold on. I want to get ready for Kahoot. But as again, Kahoot, when there's ECGs, I'll show you the ECGs before we ask the question. There's 2 questions to start with. Okay, I don't want to play the same one again. Apologies, it's a bit slow. That's really slow here. About this. Okay, let's get started. So 2 questions first. I'll show you an ECG. Yeah, so junctional rhythm, very good. The AV node luckily will take over. Yeah, very good. So you're getting escape rhythm from the His-Purkinje system. Okay, there's not escape from below the AV node as an answer, but that could be another correct answer. So because the Kahoot ECGs are not particularly good, so this is now for question 3 and 4. This is for question 3 and 4. I'll give you some time to look at this ECG. You should have the example. I sent it to you. For questions 3 and 4. It's in the T wave. So let's have a look at, let's answer the next question, then I'll show you the ECG again. Yeah, so it's a junctional rhythm. Okay. Let's just go back to that ECG, just for those that didn't get it, don't worry. Okay. So it is a bradycardia. Okay. We have a narrow QRS, which suggests that our AV node is okay, or there's an escape rhythm coming from just below the AV node. So to answer the question, if you don't think there's P waves, it's okay, because the algorithm will allow you to get to the answer. So it's a junctional rhythm. The sinus node has stopped working, the AV node has taken over. But the question number 3 was, are there any P waves? If you look, this T wave is not smooth. There's a negative P wave, okay? As well as there being a T wave, there's 2 bumps. Okay, so you don't get double bumps in, So basically you've got a P wave buried in the T wave. You can try and see. Okay, there's another example. Just look across all the leads. You can see a P wave. That T wave should be smoother. There's another one. Okay, so that's evidence of junctional rhythm, and there is a P wave after buried in the QRST. Sorry, buried in the T. Sorry, buried in the T wave. So this is question 5. Question 5. Yeah, it's irregular. I think you have to say it's definitely irregular. If I put regularly irregular as an option, that might be right as well, but it's definitely not regular on its own. Okay. So you can see it fires off, and nothing, fires off, nothing, longer. So the spacing is all very variable. So it's irregular more than not. Okay. Another bit to this, sorry. Question 5 and 6. Yeah, well done. So always right bundle, left or right axis deviation, and the prolonged PR interval. Yeah, trivesicular block. 3 things that are going wrong. Apologies, just going back to this ECG for those that want the answer. So if we walk and talk through this, we have an irregular rhythm. It's a bradycardia, intermittently bradycardic, with a QRS that's narrow. Do we have any P waves? Yes. What are the relationship of the P waves to the QRS? Well, there's this prolongation. So it's prolonged, gets more prolonged, and then the P wave doesn't conduct through to the AV node, It resets itself. PR interval's okay, a bit longer again. Oh, gets stressed out a bit more sooner on this one. So P nothing. There's this prolongation of the PR interval again before it drops. So this is Wenckebach block, or this is an example of, we can also call it 2nd degree AV block. Mobitz type 1. Mobitz type 1, so it's not so bad. Okay, this is questions. Question 7. This is question 7. Does it have to be left axis deviation, or can it be right? Yeah, you're right. It can be either. So you have to look at the axis and see, is AVL most positive? Then it would be left axis deviation. Or if 3 is the most positive lead in the axis, it can be right axis deviation. So it can be either either or. So remember, you're welcome. Remember, if it's left axis deviation, then you're affecting your left anterior fascicle of the left bundle branch block. If it's right axis deviation, you're affecting the left posterior fascicle of your left bundle branch block. Okay, that's question 7 for you. Yeah, so this is complete heart block with a narrow escape. So let's look at that ECG a bit bigger for you. So we have a bradycardia. These are the QRSs. 1, 2, 3, 4, 5, 30 beats a minute. Probably have another one just firing here. 30 beats a minute. This is a bradycardia. Is our QRS broad or narrow? The QRS is narrow. Cover, that's very narrow. Okay. Are there any P waves? Yes. What is the relationship of the P waves to the QRS? Well, there is no relationship. P wave fires, P wave fires, fires, fires. So already there's 3 P waves before the next QRS. And there's another P wave, P wave, P wave buried in there, P wave. So remember, the P waves are firing, sinus node fires regularly here, but there's no association of the P waves to the QRS. So this is complete heart block with a narrow escape rhythm. Question 8. Yeah, fixed AV block. So why is it fixed AV block? Let's have a look. So fixed AV block is another way of saying second degree AV block Mobitz type 2. So when we go along the rhythm strip, we certainly have a bradycardia. The QRS is just borderline narrow, just about narrow. Okay. Are there any P waves? Yes, it's a regular rhythm. Spacing between every QRS is the same, sorry. There are P waves. What is the relationship of the P waves to the QRS? There is 1, 2, and there's an 8 QRS. 1, 2, QRS. 1, 2, QRS. So going along here, the P wave fires, sinus node fires, the AV node's not good, can't take it, recovers, P wave goes to the QRS, fires, okay, resets itself, AV node can't fire, P wave fires, nothing happens, and P wave happens, conduction to the ventricle. Again, there's a very fixed pattern, 2 to 1 fixed block. Okay, 2 to 1 AV block. Okay, so this is second degree Mobitz type 2 or fixed AV block or 2 to 1 AV block, 2 P waves every 1 QRS fixed AV block. Okay, look carefully, question number 9. Ah, so it's the Hispurkinje. Why is it the Hispurkinje? So it's beyond the AV node because we've got a broad escape rhythm here. So it's the escape rhythm's coming beyond the AV node and the distal part of the Hispurkinje system. Okay, so it's a bradycardia. We have a broad QRS now, so it's broad. You look at all the QRSs, they're broad. So this means either there's bundle branch block or there is a broad escape rhythm. The question is, are there any P waves in this? I'm just coming to that. Okay, so yeah, there are P waves. Okay, so you've got to imagine your sinus node always fires off regularly. So you can map these P waves, but there is no relationship of the P waves to the QRS. There's probably a P wave buried in there. Another one, another one, another one. So the P waves fire off regularly. There's no relationship of the P waves. There's P wave buried in there. There's just no relationship at all. The QRS. So the level of block is much more distal than the AV node. If it was a narrow escape rhythm, then you'd say it would be at the level of block would be at the AV node. This is definitely Hispurkinje system. So it's trying to test out, your understanding of what a broad escape rhythm means. Yeah, AF with complete heart block. Apologies if I didn't show you the ECG and you couldn't see it very well. Sorry about that. So basically, this ECG, question number 10. Okay, so how do we walk and talk through this? We have a bradycardia. Look at the rhythm strip. 1, 2, 3, 4, 5, 6, 7, 8. So heart rate's 48 beats a minute. The QRS is broad. Sorry, the QRS is narrow. Okay. It's a regular rhythm. The spacing between every QRS is the same. Are there any P waves? No, but there's a suggestion of fibrillation along here. This is not, it's not a flat baseline, remember? So it's very fibrillatory. Normally best seen in V1, but you can look at all the leads to confirm. Okay. If you had flat everywhere, then you'd think about a junctional rhythm. But because this is AF normally conducts through, and you'd have an irregular rhythm with AF conducting through the AV node, but the presence of AF with a regular rhythm means that there is a complete heart block at the AV node. So you're seeing AF in the top chamber. This is the escape rhythm just below the AV node, as there is complete heart block. AF with complete heart block. And the last one, question 11. Yeah, well done. Junctional rhythm. Yeah. Well done, JB. We'll just go back to that last ECG just to show you. So a bradycardia, 1, 2, 3, 4, 5, 6, 1, 2, 3, 4. So 36 beats a minute. You have a narrow QRS, less than 3 small squares. Okay, it's a regular rhythm. It's regular. Are there any P waves? You could say no P waves and a very flat baseline there. It's quite flat everywhere. Okay, so you'd come up with a junctional rhythm. However, if you look carefully, there are some P waves after the QRS to suggest that that's the retrograde activation from the AV node backwards to the atrium. That was a junctional rhythm. Okay, thank you for tuning in for that long. Hope it's been useful. I'll try and post it when I can get time, and enjoy the rest of your evening.